Hello, hi, dear friends. This is Dr. Preetha Jackson, Junior Resident, Department of Community Medicine, and you're listening to Scientia Public Health Podcast, an esteemed endeavor towards health communication by the postgraduate students of Community Medicine, Pushpagiri Institute of Medical Sciences and Research Center. The goal of our podcast is to bring about a scientific timber on public health domains and providing a platform for regular exchange of views and information. Today, we have Dr. Jeemon Panniyamackal joining us, who is currently working as the Additional Professor, Department of Epidemiology, Sree Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. He has a very strong professional and academic record as well. He was also the award winner of Shantiswaru Bhatnagar Prizes in Medical Sciences, Council for Scientific and Industrial Research 2021. This year, he also received the very prestigious Professor M.S. Vallethan Award for the Outstanding Research Investigator, Sree Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. It's a privilege, sir, to have you here and welcome to Scientia.
Thank you very much.
Thank you, sir. Sir, it's a very curious question from a postgraduate point of view. You are a researcher, a professor, an author, epidemiologist, and a public health expert. If you were to choose one role, which one would you choose and why?
This is an interesting question, and I don't have an immediate answer to it because we wear multiple hats at multiple time points. Epidemiologist is a fancy term, but many people, the lay community, do not understand what it is. Maybe after the COVID epidemic, it start getting into the information is getting into the people, and people realizes the importance of an epidemiologist. Public health champion or public health expert is another fancy term, and it's pretty difficult for us to define who is a public health expert. In my opinion, anybody who is contributing to public health is a public health expert. Therefore, that hat would go to anyone, not only professionals, but even lay community as well. Professor or academician, yes, it's an interesting position, but I think ultimately what is important is what we are doing, what we are contributing to the society, how we are helping to improve public health. And if you are doing that, I think you should be happy about it rather than the titles that you get.
Thank you, sir. Hope that was inspiring to all our listeners. Sir, what were your experiences with regard to chronic disease conditions and its control while working in Kerala as well as outside Kerala, and which was your best experience?
Well, I have had the opportunity to work in multiple settings in Kerala at the national level in Delhi. I worked in a pharmaceutical company for a couple of years. I worked in University of Glasgow for almost 3 years. But whatever the project that we are at the moment doing, it's all collaborative projects with multiple collaborators from different universities and different institutions. So even in Kerala, if I sit and work, I have collaborators from multiple institutions. These collaborators include not only public health professionals, they are social scientists, engineers, technologists, and other professionals as well. Therefore, it doesn't matter where you are sitting and how you are working. The collaboration brings multiple expertise from multiple institutes to you, and then you would just utilize those skills and help to improve the public health. So in terms of the experience it is different in different institutions. I moved to University of Glasgow to do my PhD in medical cardiology. It was an important milestone in my life. I learned the scientific rigor from the University of Glasgow through my PhD program. I can say that the scientific rigor that we apply in our settings and in UK settings, UK university settings, it was different. And I felt that difference, I learned from it, and I could utilize and implement in the research that I do currently in India. That doesn't mean that the research that we do in our Indian settings are without scientific rigor. But the kind of training, the structured training that they have provided helped me to acquire those skills and apply in our settings. In terms of other experiences, working in Kerala and other different places, Kerala is special to me because it's my hometown, it's my home state. And I always feel that we need to give something back to the society. and I studied in Kerala throughout my schooling and also in colleges. And I feel that I have a commitment to the society because it's all taxpayers' money that I spent for my education. So it was important for me to come back to Kerala. And when I got an opportunity to work with the Sree Tirunal Institute of Medical Science and Technology, there was no second thought. I moved to Kerala immediately. Of course, family was an important reason because all my family and close friends were in Kerala. So that was another reason why I moved to Kerala. But otherwise, when you're working in public health, anywhere in the world you are, it doesn't matter because the world is connected and you need to work with multiple institutions. In silos, you can only do certain things, but when you collaborate with multiple other institutions, you can actually move mountains.
Sure, sir. That shows your sincerity and dedication for your work, sir. And definitely collaboration is a key point to progress. Sir, monitoring the progress and trends of NCD and their risk is important for guiding policies and priorities. So, can you please state what is the current trend of NCDs in our country as well as our state, and how are the major risk factors going to contribute to this burden of NCDs in future, say 2050, taking into account the societal future trends?
Yeah, I think that's an important question that all of us need to understand. Non-communicable diseases is already emerged as an important contributor to both mortality and morbidity. So if you look at the mortality pattern at the national level, we have around 10 million deaths, close to 10 million deaths annually. So of these 10 million deaths, at present approximately two-thirds are attributable to non-communicable diseases. And even if, when you consider disability adjusted life years, even if you take into account disability as well, the trend is almost the same. So predominant contributor to both mortality and morbidity is non-communicable diseases. But the Indian situation is different from the other countries. See, we talk about epidemiological transition. The transition from predominantly non-communicable disease, predominantly communicable diseases, maternal and child health conditions, and nutritional disorders to non-communicable diseases. This transition is important. The transition period is also important. If you're looking at the transition in the Western settings, it took almost 90 to 100 years for this transition to happen. Whereas in India, if you look at it, this has happened over a very short period of time, say for example, in the last 2 to 3 decades. So that dramatic transition has its own implication for our health system because we have been struggling to contain the infectious diseases, maternal and child health conditions, and other nutritional disorders. Our entire health system was oriented towards tackling these problems. We are not saying that we have completely tackled these problems already, but the predominant cause of death and disability is now non-communicable diseases. Because of this drastic epidemiological transition, we are now grappling with this big problem of tackling non-communicable diseases. Within the non-communicable diseases, if you look at it, of the 10 million deaths, approximately 2.6 to 3 million deaths are attributable to cardiovascular disease condition. So that's the predominant cause of death in India. And this is pretty much the same situation in all other countries except few Western settings, high-income settings where cancer has overtaken cardiovascular disease conditions because of the dramatic changes at the population level and also in terms of the management of these conditions, the mortality rates over a period of time reduced in high-income settings. Whereas in the Indian settings, it's either increasing or it remains at a higher level. But then India is a huge country. There are variations across Indian states. There are variations across districts within India. So you see this diversity in India wherever you go, whether it's in a particular district or in a state or across India. The types of cardiovascular disease condition are different in different regions. Say, for example, in Kerala, now we have ischemic heart diseases as the predominant cause of death. But if you go to some of the northeastern states, the predominant cause of death is stroke, not ischemic heart disease, predominantly non-ischemic types of strokes. So this diversity is there in our Indian settings, and it is there in different states and different districts as well. And then if you look at what are these conditions that are leading to cardiovascular disease conditions, the predominant one for the Indian population is high blood pressure. There is no doubt about it. At present, our estimates are, we have approximately 180 to 200 million individuals with hypertension, either diagnosed or with elevated blood pressure levels. They are not being diagnosed. At least 40% of them are not diagnosed in the Indian settings. But if you estimate the number, it is approximately 180 million people. It's a huge number. How do we tackle them? They need regular medicines. They need regular support in terms of self-care. Otherwise, it would lead to complications like cardiovascular disease conditions and stroke. If you look at diabetes, the situation is pretty bad in the Indian settings. We have approximately 105 million people with diabetes. And what is more important for us to understand is that it's not only the people with diabetes. Now we have approximately 140 million people with the pre-diabetes condition. And the data shows that the pre-diabetes to diabetes conversion in the Indian settings is pretty fast. If you look at the conversion rate over a period of 5 to 6 years, it is approximately 1/3. That means 1/3 of these people would convert into diabetes in the next 5 to 6 years. That we cannot afford. Now, if 1/3 of 140 million people gets added to already 105 million people, it's going to be a huge task for the health system to manage them in the community settings. So these conditions, predominantly diabetes and hypertension, are the predominant reasons why we have elevated number of incident cases of ischemic heart diseases and stroke and other cardiovascular disease conditions. But no, we cannot ignore other risk factors like tobacco, because tobacco is also prevalent. Alcohol use. Alcohol is also widely prevalent in our settings. And if you look at physical activity, the physical activity levels, especially in the urban settings, are very poor in our settings. And if you look at women, especially in Kerala, the physical activity levels are very poor. And why? We have been talking about the contribution from the mortality or the morbidity attributable to non-communicable diseases. But physical activity is an important thing that we can tackle in our daily life. But we often forget about it. We often ignore about it. We don't need heavy infrastructure to do physical activity. At our personal level, with minor modifications, with minor adjustment, we could improve our physical activity level without much investment, without any additional costs. But then people are not motivated, or people are not willing to do this additional effort to control the epidemic of non-communicable diseases. Partly because people are not aware about it, partly because people are not aware about the benefits of physical activity, and partly because our health system or people, the health professionals, are not communicating the message rightly to the public that physical activity is important. So it is important also for us to practice it if we want to preach about it. But often what we see that, especially among the health professionals, even the health professionals, physical activity levels are very low. So these multiple risk factors are contributing to this cardiovascular disease epidemic or the non-communicable disease epidemic. And one of the main principles of non-communicable diseases is that if you have multiple risk factors at the same time, your total risk for a non-communicable disease, a major event, is relatively on the higher side rather than having intuitively elevated single risk factors. And that is something that we need to watch out for. If you actually look at our patient population who are seeking care from our primary health centers, large number of them have multiple risk factors at the same time. Large number of them come with multiple conditions, non-communicable disease condition. We call them multimorbidity or multiple long-term conditions. And that's the current crisis of our health system. Our surveys estimates suggest that at least 2 of 5 people who are seeking care from primary healthcare system in Kerala, they have multimorbidity. Our surveys also suggest that at least 7 of 10 households in Kerala, they have at least one individual with multimorbidity. Multimorbidity is not easy to manage. When you have more than one conditions, the standard guidelines or the treatment protocols often doesn't work because these conditions interact each other. The drugs interact each other. So we need to have new models of care for managing multimorbidity in our setting. Unfortunately, we haven't recognized that even in our policy documents. If you look at it, people often ignore the problem of multimorbidity. Even the term multimorbidity is new to our policy makers, unfortunately.
It was very well said. and it was very insightful, sir. So definitely, it is high time we change from a treatment-centric point of view to preventive point of view. So even before the coming of COVID-19 pandemic, many have emphasized that the digital health is very important in the prevention and management of non-communicable diseases, especially because it plays an essential role in integrated care, delivering precision medicine, and improving the medication adherence, etc. How do you think, sir, the digital health can possibly influence the outcome in the management of NCDs?
That's an interesting question. But before I come to the question related to digital health, let me a little bit discuss about the COVID situation. So we were all worried about the COVID situation, COVID-related deaths. People were panicked because of the COVID situation. The health system was struggling to cope up with the management of COVID situation. We have seen it not only in Kerala, other parts of India, that how the health system struggled during the COVID period. But if you look at the mortality attributable to COVID and compared it with mortality attributable to non-communicable diseases, even within the non-communicable diseases, cardiovascular disease alone is causing much more mortality annually than the the mortality attributable to COVID. But people are not recognizing that. Now, it's at least 5 to 6 times more for cardiovascular disease mortality. Even if you look at hypertension or high blood pressure related mortality, it is much higher than the COVID mortality. But why people are not recognizing it? Because it's often a silent killer. It doesn't happen overnight. So it happens over a period of time once you have these conditions, and these conditions remains as silent without any symptoms. And you would only recognize it when you have a heart attack or a stroke. And that's unfortunately the situation in our community settings. So let me come to your questions related to the digital health. Yes, digital health, especially in the last 5 decades, has dramatically improved all over the world. And we have utilized it, especially during our COVID time, in terms of managing COVID cases. So there were a lot of development recently happening, especially introduction of new models of care, new models of digital health, incorporation of artificial intelligence tools into the digital health. And it all helped in terms of providing better care for people, especially in improving the care delivery to individuals based on their individual characteristics. These are all important. But then we also need to recognize that when the technology comes in, there are issues associated with technology as well. One of the main issues is that we are not getting sufficient time to interact with people, and we are not often getting the personal connection with the patients. For a physician who is sitting in a primary health center or anywhere else in the secondary or tertiary healthcare settings, it is important that they interact with the patient. And for the patient also, it is important for them to directly interact with the healthcare professionals, because they put a lot of trust on the healthcare system and the healthcare professionals. And the other issue is that who can use this technology. So at present we all say that mobile phones are available in all the households, at least in the Kerala settings, and at least to an extent 60 to 70% of the households at the all India level as well. But that doesn't mean that this technology, even the mobile-based technology, everyone can utilize it. Because to utilize that, it has a learning curve, and it takes time for people to utilize it. And it requires not only the access to the mobile phone technology, but also the understanding of how the technology works through the mobile systems. So the technology has its own implications. It has a potential to widen the already existing health inequity, because the poor and the marginalized are the people who are often getting alienated from this technology. Unless we address them through technologies, unless we understand the context where people live, and then use the technology appropriate for them, we may not be able to improve the health of especially the marginalized people. I think technology is important, there is no doubt about it, but we need to utilize the technology according to the context, and then fine-tune the technology so that it actually increases access to healthcare rather than alienating some people like the marginalized from the health system.
Yes, sir. Let's be hopeful about how technology is going to take a positive impact on our healthcare system. Sir, you are a health economic person too. So, how do NCDs impact individuals and society from an economic perspective?
Yeah, I think let me say that I'm not a health economic professional. Yes, I studied health economics, I understand health economics, but I wouldn't call myself as a health economic expert. But let me try to address your question. So you talked about the economic impact of non-communicable diseases, different types of non-communicable diseases. It has an important impact at the household level as well as at the micro level. If you look at the micro level, say for example at the household level, we all know that the out-of-pocket expenditure associated with the non-communicable disease conditions are relatively very high as compared to other conditions. If you look at catastrophic health expenditure at the household level, some of the non-communicable disease conditions like cancers, they have catastrophic health expenditure to the tune of at least 70 to 80%. And for certain types of cancer, it goes up to 95% to 100%. Because whatever the background you have, whatever the amount of money that assets you have, these conditions actually takes away all these all your savings and then put your family into distress, and that leads to catastrophic health expenditure. And if you look at cardiovascular disease conditions, most of these cardiovascular disease conditions like heart attack or stroke or similar other events also associated with a high out-of-pocket expenditure, and at the household level, relatively higher catastrophic health expenditure and distress financing. People often, since they don't have the enough savings, they have to either sell their gold or pledge their property or borrow money from bankers at that point or from friends to manage these acute events. So the out-of-pocket expenditure, even not only during the acute event, even after the acute event, in terms of managing these conditions, is also relatively on the higher side. If you actually look at the data from various studies, it suggests that the out-of-pocket expenditure due to non-communicable diseases are at least 4 to 5 times higher than the out-of expenditure due to other conditions, because it's not only the OP care, the hospitalization rates are also relatively higher with the non-communicable disease conditions. And then, at the macro level, if you look at it, that's very important for us to understand. People think that earlier people were saying that non-communicable diseases are the diseases of the rich in the society, so we don't need to really worry about it. There were also earlier, very experts in the health system, academicians from the Western world, even suggesting that investing on non-communicable disease management in countries like India is probably not a priority, because they need to tackle the infectious disease conditions first, without realizing the economic impact of non-communicable diseases causing to the lives of people in India or even in Kerala. But then later that thought process has changed. Why that thought process has changed? There were studies documenting that it is disproportionately affecting more people in the lower educational status. It is disproportionately affecting more people in the lower socioeconomic status. So when we are thinking about their paying capacity, since they earn only enough to meet their daily meals and what they need to pay for the rent for their houses, they don't have enough savings to pay for the healthcare expenditure. So all this leads to increased out-of-pocket expenditure for them, and that's actually causing even distress within the families, and that pushes families back to poverty again, and that vicious circle continues. And those who are in poverty, then they get cardiovascular disease conditions or other non-communicable disease conditions, because they don't have better access to care, they don't have better access to healthy food, and often they have all the exposure to other risk factors as well. So that vicious cycle continues, and again, they will go back to poverty. So this is an important thing that we need to tackle at the community level. Our estimates also suggest that at least the back of envelope calculation suggests that on an average in India we are spending at least to the extent of 2.5 to 3 lakhs rupees out of pocket per capita in the Indian settings. That if you calculate further, it adds to approximately 7 to 9% of our GDP. So can we think about out-of-pocket expenditure, 7 to 9% of our GDP, spending on health alone? Whereas if you look at the overall health expenditure, it's less than 1.5% now. So we are spending a lot of money on healthcare expenditure, and most of this money is going as out-of-pocket expenditure. We need to tackle this problem. Unless we tackle this problem, this would further emerge as a big problem for our community, and we would not be able to adjust to that conditions, and many people, many lives we will not be able to save.
Yes, sir. Definitely those numbers are very disproportionate. Sir, in your research, what evidence have you found regarding the cost effectiveness of prevention strategies for NCDs? And also, are there any specific NCDs that tend to have a more substantial economic burden, and why is this the case?
That's a very difficult question to answer. We have very limited literature on cost effectiveness of prevention strategies. There are two reasons for it. One, people don't give it as sufficient priority to look at cost effectiveness of prevention strategies, because many people argue that we just need to implement it without actually doing an analysis on cost effectiveness of prevention strategies, because we know that it works based on the evidence from the resident settings. But researchers don't buy that argument completely, because we rely on actual data generated from our community settings. So if you look at some of the programs that have been implemented, especially diabetes prevention program, we have something called Kerala Diabetes Prevention Program, which has been a pioneer program in terms of diabetes prevention using it was a peer-led program for managing diabetes in community settings in Trivandrum in Kerala. We looked at the cost effectiveness of the diabetes prevention, the Kerala Diabetes Prevention Program, and we realized that it's a highly cost effective program. And for certain section of our society, especially people with impaired glucose tolerance, it's actually a cost saving program. And there are multiple other prevention strategies that are either cost saving or highly cost effective. So the whole argument is that there is no real need to look at cost effectiveness. We can just go and implement these prevention strategies, because we know that this prevention actually works in the community settings. But then we need to generate supporting data, especially to influence policy. That's very important. But then your second part of the question was related to
Any NCDs that can cause economic burden, the increased economic burden, any specific NCDs?
So actually, if you look at all the NCDs lead to high out-of-pocket expenditure and it's lead to economic burden, there is no doubt about it. But within NCDs, as I alluded to it earlier, cancer is a condition that's associated with very high out-of-pocket expenditure, and cancers are also causing a lot of catastrophic health expenditure in the household. After cancer, it is the cardiovascular disease condition like heart attack and stroke. Stroke is very important. After a stroke event, even if that person survived after the stroke event, the healthcare expenditure is relatively on the higher side, especially in terms of rehabilitation. And therefore, the catastrophic health expenditure associated with a stroke is also very high in our community settings. Chronic obstructive pulmonary diseases. The out-of-pocket expenditure associated with chronic obstructive pulmonary diseases is very high. And largely it is to manage the routine care as well as to manage the exacerbations. And often these exacerbations lead to hospitalization, and any hospitalization leads to high out-of-pocket expenditure. Even if it is within the public system, it is associated with high out-of-pocket expenditure. So if you actually look at all the non-communicable disease conditions, they are leading to high out-of-pocket expenditure and issues within the household finances. And within the NCDs, probably cancer is leading one of the leading causes.
Thank you, sir. So you told me you are not a health economics person, but still I think you'll be able to answer my question. How can health economics help the policymakers in making informed decisions about the prevention and management programs of NCDs regarding the allocation of resources?
Yeah, I think that's a crucial part of it. For a policy maker, if I have 100 rupees or $100 in my hand, and that's a limited pot of money that I have, I cannot spend that $100 or 100 rupees on everyone or for every conditions. I have to prioritize it. And how do I prioritize it? And one of the main thing that people use is the cost effectiveness data. If I know that certain interventions work, I probably tend to invest more of my money to that portfolio rather than interventions where we don't have evidence or where we know that it doesn't really work in the way that we anticipate it. Therefore, it is important for us to generate this data, and the cost effectiveness data are often useful for policymakers. But let me say that policymaker doesn't always rely on cost effectiveness data to, especially in terms of resource allocation. Why it is that? Because we have a commitment to take care of the health of everyone in the society. So say for example, if you actually look at some of the orphan conditions that are not very common in our community settings, and if you say that there is not enough cost effectiveness data to invest our money to tackle this problem, can we ignore them? Of course, we cannot ignore them. We have the ethical and moral responsibility even to consider them and allocate part of our resources to take care of their health as well. It is not because it is not their fault that they develop these conditions. At the societal level, at the state level, or at the national level, we have the commitment to tackle their problem as well. So we don't often rely on cost effectiveness data in terms of the resource allocation. We often go beyond that and look at ethical and moral, our ethical and moral responsibilities as well. But having said that, cost effectiveness data, if it is available, it helps the policymakers to allocate a reasonable chunk of our money to those interventions that actually works in the community settings.
Thank you, sir. That was a very practical and a very insightful answer. So could you please share with us few examples of any successful NCD prevention and intervention programs that have demonstrated a positive economic outcome?
So I always, I alluded to the Kerala Diabetes Prevention Program. It was a highly cost-effective program in the Kerala settings. We conducted a family-based cardiovascular risk reduction program in community settings, again in Kerala, in high-risk families with an incident case of premature coronary artery diseases, and where the family-based interventions was much more effective than individual-based interventions, and we demonstrated that it actually works in the community settings, in our settings. We haven't published on the cost effectiveness data, but we have access to the data, and it tells us that these interventions are actually helpful even in terms of even in the shorter 2-year time period. The within trial cost effectiveness data indirectly telling that it is actually a cost effective intervention. But one of the main things that we need to consider for prevention strategies, people generally accept that they are important interventions, they are cost-effective interventions. But to demonstrate the cost effectiveness within 2 years or within 5 years is a difficult task, because the fruits of the prevention happens at a later point in time, especially a later point in our lifetime, later years of our lifetime. Therefore, to demonstrate that it actually cost saving or cost effective, we need to continue this intervention, or we need to follow up these people over a longer period of time. So wherever studies that we have conducted and which has got longer term follow, it actually tells us that these interventions are actually helpful in delaying the onset of diabetes, in delaying the onset of cardiovascular disease conditions. We need to recognize that delaying the onset of diabetes is a powerful intervention. If you could delay the onset of diabetes by 1 decade, at least by 1 decade, the average life expectancy would increase by approximately 4 years. And it's not only just life expectancy, it's a quality adjusted life expectancy. You have better quality in the remaining period of life. Therefore, it is important to invest in these prevention strategies. And there are multiple other models that have been demonstrated in other settings, largely looking at cardiovascular risk reduction in the community settings. We have robust data to suggest that these prevention strategies actually works, and they are actually cost effective as well. And not only in terms of the primary prevention strategies, it is important for us to think about people with diabetes, people with hypertension, people with other non-communicable disease conditions. We need to provide appropriate management to them so that they could prevent potential future events or future hospitalization or future acute events. And to do that, we need to develop appropriate treatment guidelines and protocol that are appropriate for our settings. Yes, we know that these strategies actually works in our settings. These strategies are highly cost effective as well. And one of the conditions, so I alluded to the problem of multimorbidity. One of the main problem people face with multimorbidity is that the pill burden associated with it. They need to take more than 3 or more than 4 drugs to manage their conditions. And this pill burden often leads to poor adherence. And one of the strategies to tackle that is that people are proposing single pill combination drugs. We have multiple combination pills that are available, but using those single pill combination drugs in our primary healthcare actually change the adherence pattern. That's what the evidence suggests. It also tells us that it helps them to improve their blood pressure control status, blood sugar control status, as well as the lipid control status. And it actually helps to prevent future cardiovascular disease events or future non-communicable disease events. And if you look at the data in the of the single pill combination drugs, most of these drugs are actually doing a very good job, a better job in terms of managing these risk factors or non-communicable disease conditions. And that is one of the reasons that recently WHO has accepted single pill combination drugs into the essential medicine list as well. And that would probably dramatically change the way that we work in our primary healthcare system. If it is available in our primary healthcare system, it actually helps the people to manage their conditions. And if they manage their conditions, non-communicable disease conditions, appropriately in the primary care settings, it would prevent exacerbations, it would prevent future hospitalization due to future acute event. That would be cost saving for the health system as well. And it also, in terms of at the population level, if we could decrease the number of hospitalization or number of acute events, that gives a lot of time for the health system to manage the number of cases that they normally receive. If that number exceeds disproportionately, the health system would collapse. They would not be able to give appropriate care for everyone. That would lead to high mortality in our settings.
Thank you, sir. So, what role does the health insurance or lack thereof play in the economic impact of NCDs, and how can this be addressed?
So that's a very important question. It's a very difficult question to answer that as well. But let me address that based on the data that we have, at least through our studies. If you actually look at 5 years back, before the Ayushman Bharat scheme, the number of people with insurance access was very small proportion, and most of them would have access to some private forms of insurance or through ESI schemes or the RBSY scheme or different government social security measures. But largely it was led by the private industry, and the private insurance was the major player. And who can afford the private insurance? Relatively socioeconomically advantaged people. The poor and the disadvantaged people would never get access to the private insurance. But then things have changed dramatically in India, especially after the introduction of the Ayushman Bharat scheme, and people have got access to this social security measure, and therefore part of their, especially the hospital expenditure care, has been taken care by the social insurance, the health insurance policy of the Ayushman Bharat scheme. And if you look at actually whether it's actually helping to reduce the out-of-pocket expenditure at the community level, at the population level, and that's an important question that we need to answer as well. Limited data are currently available in terms of whether it is actually helping to reduce the out-of-pocket expenditure at the community level. The data that we have from our registries, especially heart failure registries across India and in Kerala, it suggests that actually the out-of-pocket expenditure is decreasing because of the Ayushman Bharat scheme, the social security measures. It also helps us to reduce the catastrophic health expenditure and distress financing at the household level. But the impact is limited. And to have that to wider impact or the larger impact, these policies people need to get access to these policies, people need to enroll in these policies, and the coverage needs to increase. And not only the coverage, the access to the hospitals where they could utilize this facility should also increase. And once we see that, I'm hopeful that in the near future it would actually help us to reduce the out-of-pocket expenditure at the population level, and it actually helps us to reduce it, especially in the disadvantaged population. And therefore, that is very important, and that would contribute to reduction in a huge expenses for these marginalized group.
So here again, it is the out of my inquisitiveness, the student in me is asking you. There are different ways by which we are quantifying the economic aspects of NCD. So are there any challenges, or what are some of the challenges while quantifying the economic aspects of NCD or economic impacts of NCDs, and what are your approaches, or how do you approach to address these issues?
Well, I think collecting economic data is a difficult task, especially in our community settings, in our population. Because often it is very difficult for us to get access to quality data, because people don't report their income correctly. People don't report their expenditure also correctly. But we largely rely on the expenditure pattern, and that's what that's what helps us to calculate the cost associated with these conditions. The actual cost is very difficult for us to determine. The other problem that we encounter is that people often seek care from non-physician healthcare workers, through our sub-centers, through our primary healthcare centers, through our taluk hospitals or district hospitals, or our medical colleges. But how do we cost the activities that's happening at different levels? It is very difficult for us to determine the unit cost for each OP admission, each IP admission, and you all know that it varies from settings to settings, departments to departments, wards to ICUs and intensive care units. Therefore, to have this data available to us and use that data for our calculations is very important. But unfortunately, in our settings, we have very limited information that are available. We largely rely on surveys conducted 3-4 years back. And we all know that in the last 3-4 years, there are dramatic changes in the health system. If you look at the Kerala health system, the reforms in the Kerala health system was, especially in the primary care settings, was very prominent in the last 4 to 5 years. We have family health centers. As part of our Ardram program, we are offering many more services through our primary health care centers. So the costings also changed according to that. So to account for that, we need to have ongoing system of collecting information at regular interval and converting that into cost per unit healthcare delivery. Unless we get that information, it's very difficult for us to calculate the data required for cost effectiveness analysis. There is progress in terms of collecting the data, in terms of utilizing and getting access to the data as well. But then we need to do much more so that people across any researchers would be able to do that analysis if they want to do that analysis in their own settings.
Thank you, sir. Now, one last question, sir. How can individuals and communities contribute to the prevention and management of NCDs from an economic perspective?
I think we all need to realize that we have our personal responsibility to tackle this problem as well. And then health needs to be as part of our discussions in our early life. Say for example, we have clear data from India says that non-communicable disease conditions, especially the risk factors, the occultation happens much earlier in the Indians as compared to the Western or the Caucasian counterparts. By the time that we get into 25-30 years, we get one of these risk factors or non-communicable disease conditions. So that's not desirable. So what's happened is that people live with that condition for a longer period of time. And say for example, if you live with the diabetes and hypertension for a longer period of time, your chances of getting a cardiovascular event, a major cardiovascular event or any other non-communicable disease events is on the higher side. So that exposure period is relatively on the higher side. How we can cut down the exposure period? We need to improve our health early in our life. And where should it start? It should start from our mothers. And if all our mothers are healthy, we could assume that all their offsprings also will be relatively healthy. And if those offsprings are brought up in the appropriate way, where we have given sufficient importance to health, especially focusing on non-communicable disease health, that would help us to create a generation of healthy people. So health needs to bring into our daily conversations that's happening. Health is an important aspect that we need to consider when we are talking about any other policy measures that we take. And early in our life, if we are able to bring in these changes, the fruits of it we would see it later in our life, especially after 40s or 50s. Where we don't get these non-communicable disease conditions. So we need to change from a concept of risk to health. That's very important for us, and we need to realize that early in our life. And we have our personal responsibility towards our health as well. So if we are not healthy, it's actually causing burden on the society where we live. Therefore, it is important for us to take care of our health. So the prevention concept needs to come into our early life. And if that happens, we would be able to avert a lot of these events to the later part of our life. If you look at the data from India, a large number of these non-communicable disease events, major events, happen before the age of 75 years or 70 years. That's not desirable. If we can push them beyond 70 years or 75 years, that would be an ideal situation. That we would, that would be only possible if we take appropriate measures early in our life. So we say that non-communicable disease program actually needs to be integrated into our reproductive and child health program. And if we are able to do that, if we get healthy adolescent girls, healthy mothers, and through that healthy offsprings, and then if you bring them up in the appropriate way by focusing on NCD prevention early in life, we would be able to delay the onset of hypertension, delay the onset of diabetes, delay the onset of cardiovascular disease conditions, and all other acute events to later in our life. If it happens after 70 or 75 years, we are not really worried. If it happens in our productive life years, we are all worried because it affects our productivity. It affects the productivity of the society. It affects the productivity of our country. It affects our GDP growth as well. We all know that we rely on our GDP to improve our infrastructure, to improve our living conditions, to improve the way that we enjoy our life as well. Therefore, any burden on our GDP would actually impact our life in our community settings.
Yes, sir. As sir said, we should be focusing more on the life cycle approach. We should start with healthy mothers, giving birth to healthy offsprings. They grow up into healthy adolescents. Again, they bring up healthy offsprings, and thus delaying all the acute events is the key point for the successful prevention and management of NCDs in our country. Thank you so much, sir, for your precious time from your busy schedule. Thank you.
Thank you very much.
Thank you, sir.
Thank you for inviting me to this program. It's been a great pleasure to interact with you, and I look forward to see more similar interactions in the future and future collaborations in research as well. Thank you very much.